So next up, that's a perfect segue into talking with Rebecca Pipkins. While she's getting her screen going, I'm going to launch a very quick poll that will help her because I want to know if you've ever been on board a mobile health unit or clinic. So if you have time to answer that question, that would be great. And she's going to talk a little bit about St. Mary's, which actually serves several of the counties that we hope to serve as well. And we hope to learn from the lessons that they have learned in their 10 years of serving Tennessee in all different areas.
Hello. As Christina said, I am Rebecca Pipkins. I'm with St. Mary's Legacy Clinic. Thank you for having me today. So we are a mobile clinic, pretty much a doctor's office on wheels. We go to 10 different counties, 10 different locations in East Tennessee, providing free primary health care to the uninsured. So we provide primary health care, point of care testing with same day results. We'll do personalized patient education before they offboard the clinic. We also, if they need any kind of advanced care, you were just talking about CAPA and all the project access in Tennessee. We definitely use CAPA quite often for any referrals for advanced care. And then we also offer telehealth consultation in the interim. Since we are only in a community once a month, oftentimes our patients do need a little bit more care in between, and so they can schedule a telehealth appointment with us. So here's the communities that we serve. We do provide all of the care items that I just mentioned in all of these counties and locations. You'll see that we double up in a couple counties, Cumberland County being one of them, Granger County, and Sevier County. And we go on the same day of every month to provide a continuity of care for our patients. So they don't have to wonder when we're going to be there next. If they are a patient of ours in Athens, Tennessee, they will know that we will be there the third Thursday of every month. There are only a very few exceptions to that, and that's if a holiday falls on one of those days, but we don't cancel. We just reschedule to a different day that month, and we just let our patients know. So we rely on a lot of people to make our clinic run and go to all these different counties. We do require a host site. We have to have somewhere to park our 40-foot clinic, and we have to have an indoor space as well. So every time we go to a clinic site, we park our vehicle and then we set our vehicle up to see the patients on board, but we also set up an indoor space as well so that we can welcome them with a hospitality table. We'll get them registered if they're our first-time patient, and if they're not a first-time patient, we'll just verify their information just like you would at a normal doctor's office. And then we'll go ahead and with our nurse volunteers, we'll go ahead and do our triage station. So we'll get their vitals, their blood pressure, things like that we can do to save time for our providers when they actually get to see the patient on board. We want them to have as much valuable time with the providers as they can. So we try to get as much of the little nuanced things done before they even go on board. Unlike going to a doctor where they are billing insurance, we get to spend as much time with the patient as we want to, which is a real blessing for us and for the patients. So you can see on that photo there on the slide, all of the different places that we go each month. So we also rely on our supporters and our schools. So the Chamber of Commerce in each county, we've joined most of them. They will help promote us. They've come and helped us do ribbon cuttings at our brand new locations. We just had one last Wednesday at our newest location in Pigeon Forge. And just we rely on student volunteers as well. And we're able to kind of be a proctor for them for their classes and get them going on their journey as well. And then you can see our many partners. So we try to bring partners with us to our locations as much as we can, because we would love to provide our patients with a village of healthcare so they can kind of come and have a one-stop shop. So you can see we've had anything from the CHI lung cancer screening bus, the UT Medical Center mammogram clinic. CHI also has a mammogram clinic that comes to our more west locations. The health departments in these counties come out and give our patients free flu shots. The American Job Center will come out when we schedule them and help with resumes and job searches. We just have so many partners that, and we want to grow that. So if you have any other partners as suggestions that could come out to our sites with us, I'd love to hear. But our goal is to be able to provide full care for our patients whenever we can. The Lions Club also comes out and gives screenings for vision and hearing. So that's really all I have, kind of short and sweet. I'm happy to take any questions. I am not a medical person, so if it's a medical question, I can certainly get back to you. But if it's anything just generic about the clinic or about the community outreach that we do, happy to answer.
Feel free to unmute or type your question in the chat. I know there has to be questions about mobile health for sure.
So Jim Peterman again. So we had a mobile health unit that came in once a month, sponsored by St. Thomas. Its home place was Murfreesboro, and it came down once a month. It turned out to be a challenge, like finding the right place. And I don't know if you've run into that. How do you get to the right place at the right time? So we were sponsored by a Methodist church that also had a food bank. So lots of people who we thought were high need were getting their food. And initially it looked like this was going to be successful because they could walk across, the yard and go to the mobile clinic. But then it turned out not to ultimately work out. And so we ended up starting another free clinic. And once that happened, St. Thomas said, you don't need us, which isn't true. But that was a challenge, I thought. And then the other thing that I was wondering is, how can we get you to come to, our neck of the woods?
Yes. So for your first question, we do a lot of research before we kind of enter into a community. So we're looking at how many hospitals do they have, how many primary care physicians do they have in that community, and a lot of that is done by our medical team. So once that is kind of complete and we've narrowed down, okay, this community, there's a real need here. Then we start searching for locations to park our vehicle and partner with that site host. And that takes a while. We really kind of do our due diligence there. We figure out, a place that aligns with our values, that has enough space for us, and that we can come the same day of every month, with no question. That's just our standing date. Part of our model, I'm kind of jumping a little bit, but part of our model is once we've done all that research and decided to come to a community, we will not leave. So we will be there through thick and thin, because we don't want any community to feel like we are abandoning them, even if there's only one patient that's coming. Our example of that is Scott County. That's probably about the third now newest clinic for us. And it has been very challenging to break into that community and get them to trust us. But again, I think it's because they've been quote unquote burned too many times, where people will come into their community and then no one will come. So then they leave. So they've been very clear with us that that's what they're expecting us to do. And we're not going to do that. And now we're up to 8 patients. And so that's a win for us, so that we can care for their community, because we know that the need is there. We know that. We've done our research. We know that they need us. It's just that they haven't come around yet. So I don't know if that fully answered your question, but we do a lot of research medically to make sure that we're not doubling up on services, and that the need is there. The next question is, how can you get us to come out? So right now, because we are only a team of 7, we can really only travel to a radius of probably about 60 miles away from our hub in Knoxville, because we travel there and back in one day, seeing patients, on the in-between. So we're already leaving our warehouse at 7:50 in the morning, and we oftentimes don't get back till about 5:30 at night, depending on traffic and how many patients we see. So we operate from 10 to 2 every day. Now in our central time zone areas, it's 9 to 1, but as you know, a 2:00 appointment, if we're backed up, they might not be seen till 3. And then, the rest is history with timing, and cleanup and all of that. So right now our model is we have to kind of stay within a radius that makes sense for everybody, and makes sense for the volunteers and providers. We do hope that one day we could have a hub here, but then also have a hub, more towards central Tennessee and then possibly in West Tennessee, so that we can just keep expanding out to all of Tennessee and not just be in East.
Yeah. Well, thank you.
Yeah.
Do you all see children or just adults? And then the secondary question is, do you have people who are consistently repeat clients versus kind of just your one problem and then not seen again?
Yeah, so that's a great question. I probably didn't say it. And it's our most important part is the only requirement to be seen by our clinic and our physicians is that you cannot have health insurance. So that is our model. We treat the uninsured in East Tennessee. So to answer your question with children and, adults, most children in Tennessee have TennCare, so we don't see them. But if you're undocumented and you don't have TennCare or access, or just whatever your circumstances are and you don't have TennCare as a child, we will see you. It's literally the only requirement we have. You can be undocumented. It doesn't matter your race, religion, none of that matters. As long as you don't have health insurance, we'll see you. Remind me what your second question was.
Repeat versus single visits.
I would say the majority are repeat. We're treating kind of chronic things. So high cholesterol, diabetes, blood pressure issues. So they're coming back to consistently get medicines refilled, because we do have a pharmacy on board and we partner with pharmacies, local pharmacies as well. So I would say the majority of our patients are repeat. And so again, they know to make their next appointment before they even get off the bus. They'll make it with our education coordinator.
And what type staff do you have typically with the unit?
Yeah, so our medical director is on staff here. So she's our main provider. That's Sister Mary Lisa. And then our nurse manager is on staff here, and our health coach is on staff. So they are the medical team that is staff related. Everybody else is a volunteer. So we typically get 1 to 2 more providers as volunteers for each clinic, and then about 3 to 4 nurses so that they can run triage. In other portions, so our hospitality and patient registration, those are volunteer-led as well, but they don't have to have medical training. So that's another about 4 volunteers. So it is the majority volunteers when we go out to clinic. It's majority volunteers, less staff, because again, we're only a staff of 7, 3 of which are on the medical team.
Sure. And then there was
a couple of quick, oh, sorry, Christy.
No, go ahead.
So I had a couple quick questions too, thinking about us getting our bus, about how much time once you get to your site, does it take you to set up? And my second part is, how many patients do you typically see in a day?
Sure. So once we park the vehicle and get it leveled out, because it's a big, like, it's not just like an RV. It has slides and it's got to be leveled. So honestly, though, because we've been doing it for so long, it probably only takes us about 20 minutes to get fully set up. So we'll park, we'll put the slides out, and all of our volunteers, they're already at the site waiting for us in the morning. So they're kind of ready like a little army, and they will help unload everything and get all the rooms set up and get the bus set up. Because if you've ever been on a mobile clinic, you know that before you travel, everything has to be strapped down. So like every computer table, if it's on wheels, it's strapped in with a bungee cord, and every chair is bungee corded in, and everything is strapped down. So you got to unstrap all those. But honestly, once you get the hang of it, about 20 minutes. In terms of patients, so we're operating for 4 hours. The max we can do is about 23. And we do that in a couple of our sites. We just know that we need to make sure that we have those volunteer providers, because one provider wouldn't be able to do that. So as long as we've got the proper number of providers, we can see up to about 23 patients in that 4 hours.
There was a question in the chat for how do you have ways you reach out to the undocumented community?
So I'll be honest, that's been kind of word of mouth and through the churches and the sites that we have partnered with. Our most the site that we have the most, migrant workers is Rutledge, and they are very, very what's the word I'm looking for? They're very connected to their church community, and that's where we go. And so the church has really helped us get that word out. And then we actually encourage that volunteers from each particular community are the ones that are volunteering in that community. So we don't travel with the same volunteers from Knoxville to all these 10 sites. We have, volunteers from Decatur helping us in Decatur, and from Rutledge helping us in Rutledge, as best we can to get fully connected to the community. So a lot of our volunteers are letting the community know as well. I do post on social media. That's not how it's getting out to a lot of the patients. It's getting out to the community that then can let their community know.
Thank you so much for
Absolutely.
your information. The website is on there, as well as the phone number. There are opportunities, I'm sure, to volunteer and help out as well.
Absolutely.
And then we'll send the slide deck out if that's okay with you. And that way you all can reference if needed. We're super excited, and we appreciate your willingness to share your work with us so that we can better serve these communities here in the next few months. And just as a side note, the results of the poll of all of you who responded, which was most everyone on the call, 68% have never been on a mobile health unit before. So again, another great presentation to tell us a little about something we didn't know. So
yeah, and if anybody on the call wants to come out and see our work, please just reach out to me, because I can try to meet you in one of the clinics that might be closest to you. We just have to make sure we set up a time either before or after patients are being seen, just to keep privacy. But I'm happy to give you a tour.
Thank you. And now we come to the real local part of our segment. We've got our faculty who have been an integral part of launching this program, who are going to do a couple short presentations just to talk about each of their disciplines, that component of interprofessional care, and then what we could expect from each discipline out in the community. And first up is Erin Melhorn, who is an occupational therapist and spends a lot of her time out in the communities doing home visits and teaching as well. So thanks for being here, Erin.
All right, thank you for having me. I hope that you're looking at the right screen. All right, so as you know, and as we've heard today, aging is a journey, and whether we like it or not, we're all on this journey together. So as you age and your parents age and you become a caregiver and a healthcare provider, it's really important to make sure that you meet the right people along the way. And I think we can all agree that the people that we've met today already are certainly members of that team. So it's my pleasure to talk to you today for just the next few minutes and let you know why it is important to have occupational therapy as a member of the team. All right. So I posted this picture on here because I don't like posting pictures of myself, but I also wanted to tell you a little bit about myself and my why. So I'm an occupational therapist who has worked in rural home health for the past 12 to 15 years. So I've been up in the hills and the valleys and the mountains, and I've seen it and I've done it. And I teach the aging courses for the occupational therapy program at UTC. I'm also part of a sandwich generation. I manage the care for my 92-year-old grandpa and my dad who has Parkinson's disease, and then those are my children. So despite my years of education and practice, I'm constantly amazed at the gaps that continue to exist for older adults. So I've learned so much today, and it's refueled my passion for helping older adults thrive at home for as long as possible. And I challenge you to think about and reconnect with your passion and your why as we all sort of join this journey together. So in every presentation I do about occupational therapy, I have to start by explaining what is occupational therapy. It's a crazy name profession that I'd fix if I could, but occupational therapists work with people across the entire lifespan. So starting with newborns in the NICU all the way through hospice. And as we know, life happens. So sometimes you're born with something, sometimes life doesn't go the way you planned and you have a car accident or a broken arm or a stroke. And so when life happens, OT steps in, and the goal of occupational therapy is to address the deficits that stand in the way of you doing what you want to do. So sometimes that would mean me as an occupational therapist coming to your home and helping your broken arm heal and get it moving, while at the same time teaching you how you can function with just one arm until it's better. Sometimes it's relearning how to walk to the bathroom safely, managing your clothing, and staying independent with bathing. Sometimes occupational therapist is helping you figure out how to make your home safer and easier to do things like cooking because you have a hard time breathing from COPD. So occupational therapists are well educated in anatomy, neuroscience, pharmacology, strengthening, and range of motion. And our goal is to promote health, well-being, and the ability to participate in activities that are important to you. And that looks different for everyone. That's one reason it's so hard to define. What's important and valuable to me might not be important and valuable to you. And so we have to really take the time to understand what people want to be able to do to be independent, have a good quality of life, and promote meaningful participation. So as we age, things change, and some of it's normal and some of it's not normal. And knowing the difference in that is really important. Falling is not normal. I know a lot of people think that as you get older, people just fall, but that's not a normal part of aging. And so older adults need to feel empowered to know I've been falling and it's not normal. I'm going to talk to my doctor about this and see if I can get some help. I wonder if it's my blood work. Could it be my balance? You know, it's important to empower older adults to take care of themselves. Frailty is not normal. It's not normal to be scared to leave your home. So helping older adults learn to remediate and compensate and overcome these challenges as they age. We like to teach older adults and really anybody we see that the more you can do for yourself, the better you feel. So at UTC and in the occupational therapy program, we're really excited to be part of the mobile health units. And what are we going to do when we're on site? I think it will evolve as the project evolves, but for now, the plans are balance screening. You know, the number one indicator of falls is fear of falling. And so talking to older adults and talking to people about the fear of falling and what we can do to manage and mitigate some of those fears that they have. Adaptive equipment recommendations, whether that be walkers or canes or wheelchairs or simple things that people can do at home when they can't pick up stuff off the floor, or if you can't reach your stove controls, or if you can't see the microwave, these are all things that we can help make recommendations. Also, strengthening chronic disease management, understanding how disease impacts your life, independence with daily activities, caregiver education. So being a caregiver is really hard. And how can we help caregivers take better care of themselves physically, mentally, and emotionally? And there's just a lot of situations that impact your ability to participate in the things that you're doing, that you love doing. Low vision, chronic disease, arthritis. But how can you keep going and keep doing and keep showing up despite these things? Occupational therapists by nature are problem solvers. And so I imagine that a lot of what we'll do is talk to the individuals that are there, see what's going on with them, and help them problem solve and figure out some resources. When occupational therapy is involved, research shows that there's an improved quality of life, reduced overall healthcare cost, increased independence with self-care, increased longevity and aging in place. There's a reduced burden of care on caregivers, and older adults are empowered to take charge of their health. So some other ways that you might see me and my students around town, I love to take them on field trips. So we run Matter of Balance every spring and typically cover 6 to 7 sites in the Chattanooga area, although this spring we'll be expanding it to some of the more rural senior centers. We do fall screening days. We run a car fit event, which is this picture right here of them by the van. And they're working with older adults to just help them understand the technology that's in their cars and how we can make your car fit and work better for you. We also provide care at local healthcare facilities, in people's homes, and in outpatient clinics. So I have to be honest, as much as my goal is to help the population that we're going to be serving as part of the rural health clinic, my goal is also to show the UTC students the beauty and value of working with older adults, especially in rural communities, and how it can become a rewarding career. Focusing on rural health during educational opportunities has been shown to increase the likelihood of rural employment opportunities after graduation. So there's a gap. There's not a lot of occupational therapists serving rural communities, and I hope that they'll fall in love with the communities and the individuals and want to continue that after graduation. So in conclusion, the focus of occupational therapists is to help you participate in things that are meaningful and to help you develop the skills to do those things. We are teachers, creators, and problem solvers, and we're excited about being part of a team that helps older adults stay as healthy and as independent as possible.
Thank you so much. Does anyone have any questions about occupational therapy?
I put one in chat, so I'll just say, I'm just wondering if it doesn't seem to me, I'm 74, it doesn't seem to me that primary care providers screen for these things, normal or not, and then make recommendations. At least I haven't had that experience. Is that sort of standard practice as you understand it?
Most individuals who are of Medicare age are as part of their annual visit, supposed to have a falls and a balance screening as well as a basic cognitive screening.
Okay, well, I guess I still have to look forward to that. Thanks.
I think like most things in healthcare, they're limited by time and resources.
Right. Is there like a website that lays all that out so someone like me could look at it?
I know that the CDC has the basic older adult stuff, but I'll have to look. I'll let you know what I find.
Okay, thank you.
All right. Next up is Dr. Kathy Scott, who is here at UTC, and she's coordinator of the BSW program. Excited to have her on board with this project and be able to bring all the tenets of social work to the communities.
Good afternoon, and thank you for this opportunity. Several months ago when Dr. Wick asked me, told me about this endeavor, I naturally was like, of course, social work needs to be involved in this. Social work is going to be very important for our students and any other faculty that are interested to be involved in this program. And through my slideshow, I hope to share, why and what social work can offer to this project. So through just my short presentation, I'll talk about a couple of things. One, the overall mission of social work, what social work practice with older adults look like, and social work practice with rural communities, and how all of those tenets or those components will inform the work that we will do on Roadmap, the social work initiative in the Roadmap program. So first, I'll start with the overall mission of social work. It's a helping profession. It's a people profession, helping in any way possible, helping any individual in society who needs our help, because the primary mission of social work is to enhance the well-being of all individuals, with particular attention given to those vulnerable populations and those who are living in poverty. And when you think about the older adult community, they are, woven all through the mission of social work. They're a thriving population in our society. Some of them are vulnerable because of the frailty and some of the conditions that are fundamental to older adults, that are common. And then, of course, as the context of what we're doing here today and what we seek to do in Roadmap is to address those who are living, in rural communities and those who may be living in poverty. So, the overall mission of social work aligns perfectly with what Roadmap is seeking to do. So social work practice of older adults, definitely, we want to present ourselves as professional and ethical practitioners with, honesty and integrity, and this whole notion of reframing aging, just making sure that we address older adults and the work that we do professionally and as respectful as we possibly can. So what do we know about older adults? We know that people are living longer. According to the United States Census Bureau, they see that the older adult population is one of the fastest growing segments of our society. As Aaron and others have mentioned, there are changes that are associated with growing older. And some of those, there are biological changes, there are psychological changes, there are changes in their living environments, they're changing, in their family structure. And social workers are trained and equipped to help navigate those changes as we age. We allow various theories to inform our practice with older adults, theories of activity, continuity, or disengagement. And we basically look at human behavior and the social environment, the life course theory, any theory that can be used will help inform the practice that we have, depending on the context of where we're practicing. And, the next point in the slide was just basically just kind of quantifying the growth that we're seeing in the population and the diversity within our older adult population. We know that on the whole, our society is growing more diverse, racial, ethnically. We have, even within the older adult community, we have those who are much older, 85 plus. I'm fortunate to have family members and community members that I live around and that I love, who are thriving at 85 and 95 years old and above. And then, of course, we know there's diversity in our older adult community in terms of where they're situated. Are they in our metropolitan and our urban cities, or are they in our rural areas? So, this just sets the context for what we know and understand about our older adult population that can help us as we embark on this roadmap journey. So social work with older adults, social work and gerontology, of course, this is one of the many specialized areas of practice, and it's aimed at helping older adults and their families maintain and improve their quality of life. I think it was mentioned, aging in place was mentioned earlier. And, if at all possible, social work practitioner wants to do All that can be done to help that older adult maintain their independence, live in the home in which they are thriving, and support their families as they seek to support their loved one aging in place. We want to promote independence and autonomy and dignity and worth. And so in order to do this, we have a general practice framework that we use. Of course, that means engagement and assessment. I heard Mr. Peterman talk about, that becoming amateur anthropologist. And I like that because, part of that engagement is really getting to know that older adult and the community in which they thrive, the community that they are part of. That's a part of that engagement process so that they can have the trust in that social work practitioner, know that they are there to really help them. And then following that engagement, of course, is the assessment. The assessment is multifaceted, or can be multifaceted term based on the context. We in social work, we have a fundamental or a basic assessment, was the biopsychosocial assessment, which we seek to gather information about an older adult that we're working with in terms of their level of functioning, their family structure, family involvement, their daily function, and their cognitive screening their cognitive functioning, their mood. It's been mentioned time and time again today, the importance of caregivers, and that assessment can include a caregiver strength questionnaire. One, because caregivers are instrumental, in older adults thriving and aging in place. And then, from that assessment, we build that plan of care. I call it, and I stress to my students, this is that who's going to do what by when, care plan. What are we going to do? What interventions do we need to put in place for this older adult that we're working with to thrive and to continue to age and maintain that independence and autonomy that we've spoken about? And, a part of implementing that plan of care could be direct practice through, counsel or providing education. But a large part of that is linking the family and caregivers to resources, community resources. So having, partnerships and working with professionals, that interprofessional practice that we're talking about is going to be very important in that resource linkage. And then, of course, evaluating the work that we've done to make sure that the older adults that we're working with are reaching their goals. And if they're not reaching their goals, how do we need to shift or revise that plan of care for success? So social work practice, we can practice in a number of settings. I think I've heard primary care mentioned. I've heard, health departments and senior centers, and all of those settings are settings in which social workers can work. And of course, working in rural communities is another area of practice, a specialized practice. And I think to be successful in what, we help our students, social work students, understand is that working in rural communities, there are a couple of things that you need to keep in mind. One, as Kristen so eloquently described, is understanding and conceptualizing what a rural community is. Automatically you want to think about, most people think about the population size, but we also need to understand there's some other structural components, as she mentioned. So just really having an understanding of the breadth and depth of what a rural community looks like. When we're practicing in rural communities, we need to really understand that we need to be culturally grounded, really understand the complexity of identity and the respect for diversity. A rural community to me is home. I grew up in a small rural town in Alabama with about 500, a little over 500 people in population. So I know that, my beliefs, my values may be somewhat different than someone who's from a large metropolitan area, the way that we handle various things may be different than someone else. So it behooves all of us, particularly social work practitioners, to really understand the diversity that may lie within some rural communities or all rural communities, and to have a respect and embrace that. We all often use a strengths perspective in our practice. We always use a strength perspective in our practice. And that basically is just emphasizing, that the older adult that we work with, they are the expert in their lives. And we should emphasize that and recognize the resilience that and they're thriving, that has gotten them to, that beautiful age that they are. And we need to champion the right. Self-determination is a fundamental but major concept in social work practice. So if one has the capacity, we respect that. And then, of course, we understand that, in working with rural communities, that, there are some challenges that have to be navigated in terms of limited resources and how we can continue to provide services in spite of those limited resources. And then, of course, we have to, combat, the loneliness and maybe isolation that could be a factor with some of the older adults that we are working with or that we may work with. So what I've shared, the social work mission, just some basics in social works working with older adults, and some basic in the social work practice with rural communities, all, when added together, they all inform social work with older adults in rural communities. And basically, this slide just this is the National Association of Social Work, our professional organization. They have set forth an extensive, this is just kind of the framework, but they have set forth an extensive set of standards that need to be considered when you're working with rural communities. And of course, this means being an ethical practitioner, having the qualifications, which would be a bachelor's degree in social work or above a master's degree, having the knowledge that have certain knowledge and skills that we've talked about, knowledge of older adults in rural communities. And when we think about the diversity and working with in rural communities, older adults in those communities, a certain cultural and linguistic competence. That means, do you know everything about an older adult in the rural communities? No, but you understand some basic concepts, but you begin from a point of inquiry. You ask during your assessment, and of course, developing the plan of care that we talked about, delivering services and monitoring those services, and then advocacy. Advocacy is a big part of what we do in social work practice, advocating for more services, advocating for those older adults who need that person to call Social Security for them, or that need that person to go down to the local social service office for other needs. So advocacy is a big part of the advocating for policy and more funding and more services to be delivered in that area. So that's just just the outline of the NASW standards for working with older adults in rural communities that will inform the work that we will do when working on this roadmap initiative. And, basically, this slide just is a little bit more information, a little bit more knowledge about rural communities and social work practice with rural communities. I won't read all of those, just for information. And then basically what we hope to do with as a part of this roadmap initiative from a social work perspective is facilitate, do that engagement assessment and facilitate caregiver support groups, provide any support and education to older adults that they need, to maintain that independence and autonomy, and lead and participate in any evidence-based program programming for caregivers and older adults. And then as we have our students who will be along with us, engage in that interprofessional practice delivery, which is very important. And then encourage students and expose students to the joy that in my social work career, that I experienced in working with older adults. And, the majority of our social work students want to work with children and families, but to get them to understand that, in that work, because of sandwich generations, or there's another term for, complex family units, that they're going to work with older adults, and having a foundation knowledge of gerontology is important. So want to enlighten students on that. So that basically is what we seek to add from a social work perspective to this roadmap initiative. And again, I'm the BSW program director for the undergraduate social work program. This is my contact information, and I'm open for questions if anyone has.
Feel free to come off mute or enter your question in the chat. Social work is going to be such an integral part of this project. I'm really excited to see the value of the interprofessional teams and how the students learn and work amongst each other. Thank you, Kathy. I appreciate you being here and telling us a little bit more about social work. And next up, we have Dr. Amber Roche, who serves as the coordinator for our graduate nursing students. She's going to tell us a little bit about her previous work in rural health and how our nurses can benefit from the programs.
Absolutely. And I am so excited to be partnering, and our students are really excited to be able to get out into the community even more. So I did roadmap, and then I added my grants have been the Candle and CAP grant. CAP is the most recent one. It's the Clinical Academic Network for Developing Leaders with Candle, and then the Clinical Academic Partnerships Breaking Down Barriers to Care. And the two grants have focused specifically on underserved populations, whether they're rural or urban settings, and training our students to be practice ready as nurse practitioners to take care of those patients. And so we know healthcare is at a crisis. We've heard that all day. We, as providers and as professionals in this field, we know that. And nurse practitioners are an excellent option for providing care in these rural settings. And as we've seen on the buses, that's who's manning them. And a lot of these rural clinics and the health departments, it's nurse practitioners who are providing a lot of that care. And so one of the things we found were not having a lot of preceptors, as we've heard today. There's not a lot of resources in these more rural and underserved areas. And so having preceptors in those areas is a challenge. And with both of these grants, what we looked at was 7 for Candle and then 8 for the CAP grant, targeting all the same counties that we're looking at with the roadmap. And then roadmap added 2 to 3 additional counties in our surrounding area. And we've seen all the statistics. These are the most underserved areas. And so what we wanted to do is really enhance family nurse practitioner students in being ready to provide primary care for these underserved individuals, knowing that that person might come to the clinic, and we've talked about social determinants of health today and how that really impacts healthcare. And you can't just say a patient comes in with high blood pressure and just give them a pill. You have to look at what else is going on in their life and what else is going on that's causing them to maybe have that high blood pressure. Are they part of a sandwich generation? Are they having to work 3 jobs and have 2 kids at home and a parent at home? So part of it's been, how do we get more nurse practitioner students into those areas? And a lot of our partners that you've heard today are doing that through the health departments, through mobile units, through primary care offices being set up in these rural areas. And so our goal has been to partner our students with those preceptors, and then also partner with those community agencies when they have a health fair, or when they're needing an extra set of hands, or they're needing help with education in a community setting. The nurse practitioner students can help do that. And then that builds that trust that we've talked about also, previous speakers have, building that trust and that relationship with those community community partners. So they know that when we say, oh, UTC School of Nursing nurse practitioner students are going to be there, they know that we're going to be there and they can depend on us. And so this is how we broke it down for the grant, looking at the social determinants of health and how we integrate all of those factors into our curriculum, doing evaluations because you have to evaluate everything, developing and improving preceptor and student recruitment and retention, focusing on those students who really want to go back and work in those rural and urban underserved areas, and then how do we partner with our community members. So this was the model that we came up with. So in our didactic education, we have a health history module. We have the People's History Walking Tour, which is very specific to the Chattanooga area. We have a spent game, and we have a poverty simulation, which literally is what do you do as a person who lives in poverty, and how do you deal with that in healthcare. Our community connections have been not only going out into the community, we do a lot of health fairs throughout the year. This fall alone, we'll have done 4 community health fairs, and that's a huge way for us to get into the community and meet the community where they are, and then also find out what else does the community need, and then how can we help meet those partners where they are in the community. And then clinical placements, which is absolutely necessary for our students to understand this community even more, is to be able to have clinical sites within these communities and get to know these folks. I'll share some statistics in a minute. This is just a picture of the poverty simulation we do. It's a very serious activity. It is not a game at all. And it simulates the life of a person in a month of poverty. And so each 15 minutes is a week in the life of someone who's lived in poverty. And I can give you more information on this if you're interested in it, but it's very impactful for the students and the faculty who've participated in as well. These are actually some of our nurse practitioner students, and all of them, the gentleman is working currently in the VA. The other lady in the striped shirt, Bethany, she is actually working at the Hamilton County Health Department in the homeless clinic, and Fatma is working in another health department, not in this area. So our students go into the community, they do these clinical hours, and then they go back into these communities for their work. These are some of the health fairs that we've done. We've done the Chattanooga Minority Health Fair now for 10 or 11 years. And what we provide with these health fairs that we do are screenings. So we do blood pressure, blood sugar, height, weight. We do tons of education. We do cholesterol screenings. And then we also provide education on what does that mean and what medicines are you taking, and do you have a primary care provider? And if you have a primary care provider, how long has it been since you've been seen? And what screenings do you need to have? And then helping partner with other communities, agencies, when we're all at these types of fairs, especially the Minority Health Fair. It's a great place to network and then be asked to help do other community type things. So this is one of my passions, is getting out into the community like this and really serving our communities and trying to instill this into our students as well. This is, you can scan this QR code. It's the Chattanooga Care Connector. This is one of the things we did probably year 2 or 3 of our grant. And it's a free resource that has free food information, free healthcare where you can get it, or low cost healthcare, dental services. It's also in Spanish. So this is something we really try to get out into the community, one through our health fairs, and then I always give cards to our students to take to their preceptor sites. So for those who don't have these resources, they can click on this website and you can search by the surrounding county, or you can search by the type of service that you're needing to find. So please definitely screenshot and utilize this. And then I'm not going to go over all the outcomes, but I did want to talk about 98% of our students post-graduation are employed in underserved areas. That's really a huge number, and 73% of those stay in primary care. And 35% work in rural areas. So of that 98%, 35 are rural, and the remainder are in more urban, underserved areas like SIMPA, the homeless health clinic here in Chattanooga. So this is something we've really worked on through our grant, is to make sure that our providers, our nurse practitioners, when they graduate, are going back into these communities. And these are some community and preceptor outcomes that we've had. I think the poverty simulation and the number of community members served at health fairs is probably two of the things I'm most proud of. We've had 600 plus community members served at health fairs. And honestly, that's just counting at this point the minority health fair. We see about 100 to 160 people every year at that health fair. And every year I've been there, I have seen people who've come back through because they say we are the only primary care they get all year long. And so trying to educate those folks and be like, here are other free resources, here are places you can go. And they're like, we know you're here and we know you're going to look at us. So that's an awesome feeling, but it's also a little terrifying because I want them in with a primary care provider when they have other needs that arise. So health fairs are a great way to connect, but I'm really looking forward to myself and our students being able to be on the bus and really get out into the community and provide that health care and where they are and meet them in those spots. And then these are all my students that have graduated in the last 3 years. And then these are my references. Thank you. So
Thank
hopefully
you.
a quick presentation.
Yeah, no, it was great though. Does anyone have any questions? Either through the chat or unmuted?
I see Kathy said the poverty simulation is great. And Kathy, we greatly appreciate you all for all of your help in putting it on.
Dr. Tony, I think you are up next. And I'm going to launch a quick poll just while she is getting slides ready. I just want to know if before today you had visited the Chattanooga Care Connector before, or if you knew it existed. All right. So most of you have heard of the Chattanooga Care Connector, which I think probably has to do with a lot of the students that are on. So 53% have heard of it and 49% had not. So hopefully you've learned another little fact for the day. It's a great resource and something that we try and support as much as we can. All right, Dr. Tony is up. Dr. Tony has her bachelor's degree from the University of Southern Mississippi. She obtained her master's degree from the University of Memphis and completed her DNP and family nurse practitioner certification through East Tennessee State University. She's a 2018 Nurse Excellence Award winner for Erlanger Health and has experience in med-surg, mental health, long-term care, case management, disability insurance. Community health nursing students under her tutelage gain experience working with school-age children, older adults, homeless and jail populations, and more. She's been a huge asset to our local public health community and, of course, our School of Nursing. Dr. Tony?
Good afternoon to everyone. So thank you, Dr. Wick, for that introduction. You make me sound smarter than I really am. So I am the lecturer, one of the lecturers for our community health nursing course here at UTC. This semester, I have the privilege of working with Dr. Natalie Owsley as a co-teacher for the course. So we appreciate her being present to help us navigate through the presence of accelerated and traditional BSN students. So in the event that my presentation does not work correctly, I do have Stephanie Blaine on standby to take over if need be. So So the definition of community health nursing, according to the ANA and the American Public Health Association, has to do with promoting and protecting our populations. And we take that very seriously within the community health course here at UTC. We advocate for promoting what are best practices for keep getting and keeping our populations in healthy, and trying to do whatever we can to protect them from many of the things that they face on a day-to-day basis. The mission here for the School of Nursing here at UTC goes along with that, because we are training leaders in transforming we aspire to be leaders in transforming nursing education and in promoting health. We do this by engaging students, faculty, and graduates in advance in health for all people. You just heard Dr. Amber Roche's presentation, which goes right along with that. And even the other disciplines that we've talked about, OT, social work, they are doing the same thing, engaging our students in advancing health for all people. We do this by developing and maintaining partnerships that benefit our students and the patients for whom they care for. The course content for community health consists of having students identify for us where they most would like to go. Most of the time, they want to go to the emergency room, the ICU, or mother-baby, or pediatrics. So community health nursing is usually not one of those things that they identify. But what we hope that they understand through community health nursing is see and understand that many of the conditions, or almost all the conditions they see in the acute care setting, have their origins in the community. So that's one reason why it's so important. Our efforts in community health help increase cultural competence and their interpersonal skills. They interact with people across all lifespans. Now, our senior adults or our older adults are the most commonly represented in the settings that we see people, but it just helps them with those interpersonal skills, learning how to communicate, that cultural competence. It also improves our community awareness of what resources are available to us out there, so that we can make those that we interact with also aware. It increases our community outreach. It helps make us more aware about health equity and deficit awareness that is going on. We also seek to, in the spring, we will be starting efforts to engage with legislators through either Nurses Day on the Hill or letter writing to their local legislators, depending on where they live, just to help them understand the importance of nursing's action in that part of our policymaking process. We are the largest provider of healthcare, yet our voice is not heard or listened to as closely as I think it should be at times. So we're going to implement that process starting in the spring, where that's a part of our course, to help our voice be a little bit more heard. We learn our clinical experiences take place in homeless encampments around Hamilton County. We also are weekly in Hamilton County Jail and Detention Centers. Many of you may know it as Silverdale. We do health fairs. As people contact me about opportunities around the city, I make it available to our students, and they get to pick and choose those things that they want to participate in. We are in our school systems. We have a big presence in Hamilton County. We have added Bradley County and Grundy County school systems this semester. So those are partnerships that we hope to see continuing, particularly in Bradley and Grundy County, as we lended assistance to their school screenings. We also go to Welcome Home Chattanooga, the Chat Foundation, or Foot Clinic. Over the summer, we added Mary Walker Towers and Riverview Towers to be a mobile foot clinic placement for us. We also participate in the Poverty SIM. We assist local hospitals and the health department with their immunization clinics. We are hoping to add in the spring those senior centers. We've been contacted by a couple in the rural areas of Hamilton County to plan some activities for the senior center. So we anticipate adding that as a learning opportunity for our students this coming spring. In the homeless encampments, this may be a common scene. We do it in collaboration with Erlanger Hospital and the city of Chattanooga. And we see people living in very desperate situations sometimes. We may also see some active drug use, and we see people not really taking care of themselves. The bigger focus is basic wound care, because these are the things that they may have to deal with as far as dog bites, drug use bites, or bug bites. We also do vital signs while we're out in those encampments. But we educate them also as to what resources are available for whatever the problem is that we see. In the collaboration with Erlanger and the city of Chattanooga, we may even provide transportation for them to get urgent or emergent care if they are willing to go to have those things done. At the Hamilton County Jail and Detention Center, we see a lot of chronic disease care. We also see acute, urgent, and emergent care needs being handled in a circumstance where there may not be a lot of technology available to tell us where or what the issue is. Community health nursing doesn't have the same kind of technology available to them that our acute care centers do. So it's really dependent on the clinical assessment needs of the nurse or the healthcare provider that's evaluating them. We have been able to see firsthand the Narcan administration, methadone administration, and the buprenorphine administration in this setting. We see how they handle mental health care needs, homelessness. We see a lot of untreated and undertreated mental health care needs, and many of the jail and detention population has to do with people who are homeless, and they may have been arrested for some type of nuisance call. But because they have been identified as having a risk, they may end up in this setting until they get a court date. We also see quite a bit of sexually transmitted infection management in collaboration with what happens at the health department. With the Bradley School, Hamilton, Bradley, and Grundy County schools, I've already said we help with health screenings, but we also see management of chronic care needs within our school system. A lot of diabetes, some increasing awareness of obesity impact on our children, even the administration of ADHD medications. And then there are the acute care needs. So sometimes it may be seizure activity or a fall or some type of injury on the playground. Our students also get exposed to social concerns, commonly coming up as it relates to safe housing, food insecurity, violence in the home and in the community, and their health and dental care needs. We actually have been using some of the Chattanooga Care Connector cards used by our F&P students in the F&P program to make sure that our school nurses are also aware of where they can send their students and their families in the event that they need some type of care. The Chat Foundation, Mary Walker Towers, and Riverview Towers is where we do our foot care. We are realizing more and more that foot care is really important to our older adults. Older adults that experience a fall, it is a high risk for death after a fall when it comes to our older adults. So if we do that initial assessment, some education, we hope that we can decrease that fall risk for our older adults. So the UT and the Chat Foundation relationship has been going on for at least 20 years. We started our mobile foot care clinic in the summer of 24, where we're going to Mary Walker Towers and the Riverview Towers. And they have been really excited to see us come in and do some foot care from them and learn ways that they can do better about taking care of their feet in hopes of decreasing their risk for falls as well. Welcome Home of Chattanooga is a hospice home and cancer respite home that we get to experience the benefit of services they provide. We have come to realize that many times cancer care, easily treated cancers, would not be recommended for care if the individual did not have a stable living environment. Welcome Home provides a stable home environment for people, as well as providing hospice home for those with a terminal illness in the event that they don't have a home to live in with their terminal diagnosis. Poverty Sim, community festivals, health fairs, immunization clinics are, as I've already stated, places where we lend our assistance. And we are looking forward to our participation in the mobile health clinic as part of the intake process as as individuals come in to be seen during that initial vital sign assessment and getting them checked into to be seen by our nurse practitioner or other providers that are other disciplines that'll be present as we go to the rural communities and service the needs of our older adults. And I know that was very, very fast, but this is my contact information for anyone that would like to contact us about possibly participating in any community activities. We have a very vigorous schedule for our community health students. So if we can fit it in, we do our best to try to be present, to have our faces and the name of UTC associated with good, reliable healthcare education and identification of resources. Thank you.
Thank you, Letitia. I know you guys are doing a lot of really good work out in the community, and that work is much appreciated. And hopefully we'll do more as we launch through the mobile health program as well. Any questions for Dr. Tony? All right, we are about to start our last presentation, and this is an opportunity to shout out Stephanie, who has been at the ready all day long, helping keep everybody on task and make sure everything's working properly. We really appreciate her help. She is going to queue up a video from Dr. Alikam. He was unable to join us in person this afternoon, so he went ahead and recorded his slides for you. And he is the public MPH program director here at UTC. He is an associate professor and has also a licensed registered dietitian nutritionist in the state of Tennessee. He's got clinical experience in family medicine and nutrition. So we're excited to hear from him now.
I am happy.
Nope.
Hi, my name is Amir Al-Akkam, and I am happy that I am presenting in the program on service for older adult and rural health symposium for the roadmap. I am a professor here at UTC, University of Tennessee at Chattanooga. I'm in the Department of Health and Human Performance, and currently I'm directing the Master of Public Health program at UTC. And I am also a registered dietitian and a licensed dietitian here in the state of Tennessee. I have a PhD in food system and master in nutrition and dietetics. I am part of the team of the roadmap presenting nutrition care and public health. I'm also involving including our student in the Master of Public Health in this in the effort related to roadmap. In fact, one of the presentation that I will present today, most of the information came up from a presentation that one of our MBA student in the nutrition and dietetics will present to one of the site of the that is affiliated with roadmap. So just a general idea about our program. So we have a Master of Public Health program here at UTC. The public health program have two concentrations. One of them is Master of Public Health in Chronic Disease Prevention and Control, and the other one is a Master of Public Health in Nutrition and Dietetics. Both concentration, they are really unique in the term of the chronic disease. One is really related more like the traditional public health degree, where they care about they provide nutrition and public health care to the community. The nutrition and dietetics one is more structured program in which the graduate will sit in the national exam and become a registered dietitian. So this is really the difference between two programs. Today, so I gave you a general idea about the program and the type of the student that you will see when we start having our boot on the ground and when we will have the mobile clinic. So you might see one of our MBHCD students, the chronic disease one, or the nutrition and dietetics one, providing public health care and the nutrition care. Which is a great opportunity for the student and also for us as university to help the community with any capacity and ability we have. I want to give you a little really brief overview of what the nutrition care means for healthy aging. So this is really some slides that provide you a general information about why nutrition is very important for older adults. So, so this is a couple of the learning outcome is that I want you to identify the benefit of healthy eating and fruit and vegetable consumption, understand how aging affect energy and nutrient target on the eating behavior, and explain the role of registered dietitian really in the nutrition care. And this will give you idea why nutrition care is important, especially for older adults. So currently the recommendation for fruits and vegetable from the USDA, which is the Department of Agriculture. This is the department that is responsible on all the guidelines related to eating habit and dietary habit of the US population. So currently the recommendation is 2 cup equivalent of fruits and 2.5 cup equivalent of vegetables and per meal. Well, actually it is per day. And the reason you will see this is a variety, so we don't really want to, especially when it comes to the older adult, we don't recommend that you consume a lot of vegetables and fruit, which is what I mean by a lot of, we are talking about like 20 cup, like 9 serving of fruit and vegetable. The reason for that, because sometimes a high amount of vegetables specifically or fruits, they will increase the fiber intake. And in case of fruits that are very sweet, they will increase the sugar intake. So you still need some type of moderation. High amount of fiber intake may reduce the absorption of vitamin and minerals, and high intake of sugar will have all the complications related to insulin regulation and the blood glucose level balance. So this is really the general benefit of a balance of fruit and vegetable intake. So you can see fruits and vegetable actually is the main player in the healthy eating habit, and it prevent several diseases, including the obesity, type 2 diabetes, certain type of cancer, like colon cancer, cancer related to the mouth, esophagus, GI tract. So we have a very long list of cancer that can be prevented if you have a healthy eating habit and if you increase the consumption of fruit and vegetables. Other diseases is really related also to fruit and vegetable intake, osteoporosis, eye disease, dementia, and there are a lot of studies currently talking about the relationship between increased amount of fruit and vegetable intake and respiratory disease. This is something new because we didn't see that before. You know, whenever we talk about respiratory disease, we talked about smoking. Stop smoking, and that's when you will have a better reduced risk of respiratory disease. But today we also see a good relationship between fruit and vegetable intake and respiratory disease that is related to the lung. And this may be due to the antioxidant benefit that fruit and vegetable give to the body, such as like good amount of B vitamin, vitamin C and E, and their relationship to respiratory disease. Those are some of the additional benefits related to fruit and vegetable. And you can see they improve cognitive function, they improve exercise performance, and also they reduce the risk of vitamin and mineral deficiencies. This is a very good study that tried to figure a correlation between fruit and vegetable intakes and mortality rate with certain type of disease. And you can see actually, based on the recommendation of 5 serving of fruit and vegetable per day, will reduce your mortality rate in general among several diseases. And if you can see specifically the risk on the respiratory disease, you will see this is actually the effect is really good and it's significant. Consuming more fruit and vegetable will reduce the mortality rate due to the respiratory disease. The nutrition is, whenever we talk about nutrition needs, is very specific for older adults for a reason. So older adults usually they reduce their physical activity and their muscle mass in general is less. That's why their calories requirement is different. Their protein recommendation is different. They also have certain complication in their GI tract, which reduce the absorption of vitamin B12. This is due to, low acidity, low high pH level in the stomach, and this is all will cause limited absorption of B12. So the recommendation for older adults is a little bit higher when it comes to the B12. Similar to the vitamin D, we see a lot of older adults, they are not outside in the sun due to the many factors. And the recommendation for vitamin D is specifically different for age 60 and older. So the calories intake is different. We also really focus on the protein intake. Protein intake is really for 60 and older, more is better. Now, you don't want to have a very, very high amount when we are talking about like 3 or 2.5 gram per day of a protein per kilogram, because this will also impact the function of the kidney, and high amount of protein could cause renal failure, renal stone, and so on. So you still need this moderation. However, the recommendation for protein is a little bit higher for older adults because their muscle mass is not that good. So the current recommendation is about 1 to 1.2 gram per kilogram body weight. So if we are talking about in general, if someone about 70 kilogram weight, so they should target about 70 to 100 gram of protein per day. Body water is decreased with age, and that's what will lead us that fluid intake is very, very, very important for older adults, and we want to make sure that they have a good amount of fluid in their diet, because it causes all those issues that you can see on the screen. And above all of this, they might have hypotension and also complication related to minerals, like low calcium level, low iron level, and other deficiencies. Some symptom of dehydration, which is very clear, is the thirst, dark yellow urine, a dry mouth. In general, any individual should consume good amount of fluid before they reach any of this symptom. So we usually drink water when we have thirst. However, this is alarming. When your level of fluid is low, then you will be thirsty. However, you should consume water regularly before you're reaching that point. So the thirst is one of the mechanisms that the body tell you that you need to drink water now. but actually you should have been consumed water fluid regularly in a way that you stay hydrated all the time and you should not feel thirsty. So fluid recommendation is not a clear cut. So you will see it's about 15 cup per day for male, and for female is 11 cup per day. However, this is include the fluid that you'll get from the food. So that's not mean you need to drink 15 cup of water per day. If you are consuming a good variety of vegetables and fruit that have fluid, for example, watermelon, cucumber, all of those, they are very good source of fluid and fiber and vitamin and minerals. Because if you get a good serving of watermelon, then you definitely don't need 15 cup of water per day. So this amount is really fluctuate based on the need, your age, the gender, weight, and the activity level, and even actually the environment. So how is the weather outside? This is also will affect the adequate intake of fluid. Malnutrition is very important topic also related to older adults, and there are tons of resources and that you can find related to malnutrition, but that's something also the registered dietitian and the nutrition care team will really assess in any visit, whether the adult is coming for hypertension check, blood pressure check, sorry, general annual visit. We do need to assess the malnutrition level and if they are at risk of any source of malnutrition. This is a very nice table that show you what is the role of dietitian or registered dietitian in the nutrition care team, and why it's very important to see a dietitian if you have any issue, or if you are coming to the hospital for a visit, because nutrition dietitians is actually part of the interdisciplinary team, and they play a very significant role in the healthcare process. Usually the clinical nutrition manager direct the dietetics team. This team may include the registered dietitian himself and dietetics technician and dietetic student. Registered dietitian is the one that will make nutrition assessment, full nutrition assessment, and create a diagnosis. For example, you have the diagnosis will be vitamin D deficiency, and based on that, we'll create a plan and we'll create an intervention method, which is usually when we have a registered dietitian, this intervention may involve your eating habit first and your food intake. So we are not going to medicine directly unless it is necessary. But the registered dietitian will make sure that will treat you in a way that involve your eating habit before move to the next level of medical or surgical treatment, which will be determined by the interdisciplinary team and the physician, the registered nurse, and the other part of the team. Registered dietitian will also involve in the post-acute care, where will they assess patient for any functional problem, work with the patient nutrition-related problem, weight loss, also coordinate with hospice care if there is a need, and also in general, the registered dietitian will provide any nutrition education that is specifically related to the person or to the community. So we do have a lot of nutrition intervention program that is targeting the community in general, and there are a lot of programs where you can find resources for nutrition care within your community. We do have a lot of online resources for nutrition care. One of the biggest one is the American Society for Parenteral and Internal Nutrition. However, this society is specifically provide information for healthcare provider. So you will not find a little bit as a general public may find it very scientific, and it's not very easy to use the resources. Well, my other suggestion will be My Plate for Adult and My Plate for Older Adult. You can see it in the figure. And also SNAP is really one of the great program for nutrition assistance and education. All those provide very good resources for older adult and their nutrition care, and will be also shared by registered dietitian when you make a visit to nutrition dietitian, or if there is a need for nutrition care. This is also another other type of local resources for nutrition care. The first one is really the Aging Nutrition Program, and that is specifically for older adult. The other one is WIC program, and I think most of you know this is very specific for women, infant, and children below, especially the children below 5 years age. Those are the references, and I think that's all for today. This is just to give you a general idea about what is in nutrition care and why it is important. We do have a lot of resources. We do have a specific, actually, a workshop that's called Nutrition and Aging, and that is hosted in the Tennessee Department of Health website. They have train.org Tennessee, and this one, it's a module, and in that module we have a specific workshop that's called Nutrition and Aging, and will give you a more in-depth information related to nutrition care. Thank you so much for watching my presentation, and I'm happy to answer any question. If you have, you can email me or you can share it with the roadmap administrator. Thank you so much.
Okay, everyone, that is a wrap. I cannot take questions on Dr. Alcon's behalf, but I can relay them. So if there are any questions, I'll post my email in the chat and I can either get you connected with him or find answers to those questions. So we so appreciate your time today. I'm going to send some links in the chat. One of them is it is a link to our link tree, which has our website information. It also has a link that you can click that takes you to the speakers information along with their presentations. We will be sending a follow-up email as well that will include all that information also. So if you missed it in the chat, and then additionally as a follow-up email will be the post-symposium survey. I also just sent that in the chat, and you have my email address. So I'll hang out for a few minutes to maybe take some questions or have any other further discussion. But thank you all for joining us today, and we hope to see and work with you soon.